All right, so for the 10th installment, we're going to talk about arrhythmias originating in the atria. Now, this is different than the sinus ones you just listened to. The atria themselves are large parts of the heart compared to the sinoatrial node, which is, of course, very small. So what different kinds can we see? Well, let's cover them one at a time, okay? You can have a wandering atrial pacemaker, or what's known as an ectopic tachycardia sometimes. So this is a passive transfer of the pacemaker sites from the sinus node to latent pacemaker sites in the atria and AV junction. What does all that mean? What all that means is that when the SA node fails, other parts of the atria can begin to take over as pacemakers. Remember that the heart has automaticity. As long as one cell in the heart discharges, the rest of the heart will often try to follow suit if it is possible. Now, this can be a normal variant of a sinus arrhythmia. It can be a normal phenomenon in the very young people and the very old people. It can also be a sign of ischemic heart disease, where the sinoatrial node is not able to function as it should over years of ischemia and other things that have gone wrong. Right? So you can also see different things. We're not going to go too deep into that. I don't want to blow anybody's mind right off the bat. So there's usually not any detrimental effects to this. It usually doesn't mean much at all unless you're using it as an overall indication of patient condition. So if you have a 45-year-old person who's a heavy smoker and cocaine abuser and they have a poor diet and high cholesterol, wandering atrial pacemaker may be due to cholesterol levels and ischemic heart disease and things like that. But overall, it's not usually a huge predictor of anything that's going to happen. It's just usually one of those rhythms you need to be able to identify to have a pretty decent idea of where your patient's status is at overall. So what are some other ones we can see? Let's talk about premature atrial contractions. So we hear about PVCs a lot. We don't talk about PACs a lot. So let's do that right now. So this is a single electrical impulse that it comes from the atria, but not the SA node. It's a premature depolarization of the heart before the next sinus beat is supposed to happen. And in these cases, you can often see a heartbeat that actually happens, so that the impulse will carry from the atria through the AV node to the ventricles, and you can see a heartbeat sort of in between beats, if you will, on the ECG. So where do we see PACs? They aren't often a big deal either. We see them in people who use caffeine. We see them in people who use nicotine, alcohol, cocaine, methamphetamine, ecstasy. It can also be seen in ischemic heart disease or hypoxia. There is not usually an apparent cause that's just kind of obvious to you, all right? Now, getting into the nuts and bolts of it. So frequent PACs may be a problem. They may indicate organic heart disease or precede other atrial arrhythmias. If the patient's hypoxic and symptomatic, you want to try to correct the hypoxia, and you a lot of times will see the PACs go away. Just kind of decide how you want to do this and go with your local protocols. Now, we'll move into one that's a little more common, PSVT. So with PSVT, paroxysmal supraventricular tachycardia, there's a rapid atrial depolarization that overrides the SA node. This usually comes on quick and goes away fast. That's what paroxysmal means. It happens without warning. It goes away without warning or treatment. You do not have to have a specific disease to have this. It can come on at any age. It can start at any age. It can leave at any age. You can see it with stress, overexertion, smoking, and of course overexertion of caffeine. And here in the monster age and with people who drink too much coffee, we often see that kind of stuff. It is sometimes associated with underlying disease, but not always. You'll kind of get a feel for it as you go through your career. It can cause angina. You can see hypotension from it. Remember that when the heart is beating over 150 beats a minute, it's not moving as much blood as it was at 140 because the ventricles don't have time to fill. So if you see someone with PSVT or SVT, you can actually see them become hypotensive, and you'll have to treat it in those cases. If the patient's stable, you want to get a 12 lead, establish an IV, have them do vagal maneuvers to have them bear down, or one of the ones I love to do is give them a syringe with the plunger about halfway out and say, try to blow and push this plunger out with the force of the air coming out of your lungs. That's a great vagal maneuver, and the patients don't often soil the stretcher, which is an important part of therapy if you've been doing this very long. Of course, and then there's Pharmacological therapy, so we can administer adenosine. So usually in the adults, we start with 6 milligrams. If that doesn't work, we start with 12 milligrams, and then we follow it with 12 more. It induces a brief period of asystole, allows the heart to rest and reset, and a lot of times a sinus arrhythmia can come out of the ashes of the PSVT or the SVT. If the patient is unstable, if they've got an altered mental status, signs of shock, hypotension, gray, that kind of thing, you usually want to use synchronized cardioversion. So you want to mash the synchronize button on your monitor, in which case you'll begin to see little arrows or markers appear over the QRS complex. You want to choose the joule setting. 50 joules is a good place to start with many patients. You set your joules and you clear the patient as you would during a defibrillation, and then you administer the electricity, and often enough the heart will shock back into a normal rhythm. You can dial up the electricity. Many places go to 100 joules or even 120 joules with certain arrhythmias. Check your protocols, make sure you can do it, and make sure that this is coming from a place where it's cardiac in origin and it's something you can fix either electrically or chemically. If your patient is hypovolemic, if they're bleeding to death, you don't need to cardiovert them. You need to put some fluid back in. You need to call air support and get blood in, that kind of thing. So just make sure you understand where it's coming from and why. So moving on to the actual SVT, which is like PSVT, except it's still going on when you get there. Treatment modalities are going to be what we discussed before, but there are a couple of things about SVT that you're going to see that I just want to cover here. So the causes are usually the same. It can also be due to some pathomimetic drug use. You can see SVT in someone who has a cocaine or methamphetamine overdose. Chemically, this is not treated the same way as the others. Generally, benzodiazepines is the way to go with this. You will need to check with your local protocols as well as the treatment modalities which are acceptable in your area. One thing I will say about this is anytime you plan to treat a sympathomimetic overdose with benzodiazepines, it needs to be a confirmed diagnosis, which generally in the field means that the patient will admit to it, or you have some other irrefutable evidence that your patient is actually doing cocaine or methamphetamine or ecstasy or any other sort of drug in that category. It could be an overdose of caffeine, etc. Okay, let's move forward from there. So the big problem with SVT is that it can cause a marked reduction in cardiac output. One finding you'll note on the ECG is that the P waves are often not discernible because the QRS complexes are so close together. And SVT generally begins around 150, just kind of as a general rule. We consider SVT at 150, but do understand that it could be 180 or 200 beats a minute in some cases. So you're going to be looking at a heart that's beating 3, sometimes almost 4 times a second. You're not going to be able to see P waves in that. So you really end up with just this narrow, complex, very fast tachycardia. And in the hypotensive patient, you can see altered mental status. You can also see angina and things. The hypotensive patient is considered unstable and is cardioverted. That is usually the biggest treatment that needs to happen there. All right, so moving forward from there, another arrhythmia at the top of the heart is atrial flutter. So what you have here is a rapid atrial reentry circuit and AV node. Physiologically, it can't conduct all impulses through the ventricles, so what you end up with is a blank to blank conduction. So one commonly used method in lecture is a 4-to-1 conduction. So you will see atrial contractions 4 times, and then you will see the actual QRS contractions. So you see the bottom of the heart essentially beat 4 times. You'll see the top of the heart essentially beat 4 times, and then you'll see the bottom of the heart beat once. And this produces the characteristic quote sawtooth end quote pattern that we see, where it actually looks like the old cross-cut saws that lumberjacks used to use with 4 small teeth and 1 big tooth in there, so to speak. It can occur with CHF. It rarely occurs as a direct result of an MI, so it's not usually a complication of an MI. It can also compromise cardiac output, whether it's the ventricles responding too slowly or the ventricles responding too quickly. Pharmacological therapy for this is almost always calcium channel blockers. However, there are many states, many places that use beta blockers that have a particular control on rate, and generally metoprolol is what you're going to see. So general pharmacological therapy in these is either metoprolol or calcium channel blockers such as diltiazem. You can also use synchronized cardioversion if the rate is greater than 150 and the patient is unstable. You do want to be somewhat careful about electrically converting these rhythms, though, as it can cause other problems, and even more so in the rhythm that we're about to talk about, which is atrial fibrillation. So in AFib, what we really have here is it's the ventricles, the atria are actually quivering. And the problem with this is that without an organized beat or an organized depolarization, they don't empty. And when the atria don't empty, blood becomes stagnant. And if you've done any studying in the triad of Virchow, you know that one of the things that can precipitate a clot is blood sitting still or blood sitting stagnant. So with atrial fibrillation, this can be chronic. Patients can go in and out of it. You can see it with congestive heart failure. You can see it with diabetes as a complication of the degradation of the conduction system and things that happens there. There's actually several causes of it. Lyme disease can be a direct result of myocardial infarction. One of the things that AFib does is it reduces the actual cardiac output by about a quarter in some cases because the ventricles don't get that atrial kick. It's what's called a kick. So because the atria don't fully empty into the ventricles are not fully extended, they're not fully distended. And in that case, you don't get as hard of a beat, which directly reduces cardiac output. So you can see hypotension, you can see infarct, you can see strokes with AFib, much higher chance of having a stroke with AFib. The biggest thing you're going to see on the EKG is it's going to be an irregular R to R rhythm. It's going to be irregularly irregular. So no two QRS complexes will be the same length apart, essentially. Each one is going to happen almost at random. One of the more common pharmacological therapies for this is calcium channel blockers such as diltiazem or what we call cardizem. And there's a couple of different ways you can administer it. Some places use a straight 10 milligram dose. Some places use 0.25 milligrams per kilo administered over 2 minutes. And then in 10 minutes, it can be repeated at 0.35 milligrams per kilo if you don't get adequate results from this. What I would like everybody to remember is that the goal of cardizem is not to directly convert AFib to a sinus rhythm. That may not be possible, okay? When we have AFib with a rapid ventricular response in a hypotensive patient and a patient that is experiencing direct instability from it, the goal is to slow down some of the actual ventricular response and give the heart a chance to fill up and produce a cardiac output that is high enough to sustain life and mentation. Now, the other therapy for this, which is generally used in the very unstable patient, is going to be electricity. It's going to be synchronized cardioversion. This is where I would ask you to be careful. If this is a new onset AFib, or if it's been going on for longer than 24 hours is really when it matters. When your patient's been in AFib for a while and they're not on an anticoagulant, they're not on warfarin or Plavix or anything like that, a clot may very well have been forming in the atria. And when this happens, you have a clot that is very loosely going to be adhered to the endocardium. And anyone here who has dissected a heart knows that the endocardium is a very slick membrane. And that contraction of the heart being revamped and the atria sort of going back to somewhat normal function, which can be the case with cardioversion. You can actually see a sinus rhythm come back from that. What you may see is a clot dislodged from the atria and then can move through the body. Now, the problem with that depends on the size of the clot. If it's a very tiny clot, you may see stroke. If it's a bunch of small clots, you may see several organ system affected. If you have a very large clot, pulmonary embolus is not out of the question. So I would use cardioversion with caution. You do not want to put your patient in a state from which they can't really be fixed. And many physicians, when it comes to atrial fibrillation, take a different route. What they often do is they'll put the patient on a calcium channel blocker to control rate and have their blood pressure sustained at a safe rate. They will then not necessarily lyse the patient, but give the patient something that will prevent clots from building up. And they may, if they choose to, take a route to dissolve any clots that are there, and then cardiovert the patient or convert the patient in a method of their choosing at a later date to ensure that the patient is safe and not going to throw any clots all around. So the bottom line with atrial fibrillation as we wrap up this section is going to be use this therapy sparingly, calcium channel blockers when you can, use electricity when you can't, but in all cases of AFib, only treat the patient if they are either hemodynamically unstable or if this is causing suffering of some sort. A stable patient with atrial fibrillation should be evaluated by a physician and should have a chance to have their PT and INR checked and let the hospital and the lab values that they collect make definitive treatment decisions on this. This is definitely one of those cases where, as a paramedic, just because you can doesn't mean you should. You should have some sort of signs and symptoms relating to instability before you treat this. You should not just administer a calcium channel blocker or cardiovert someone who just simply happens to be an AFib. All right, and we'll move to AV arrhythmias after this.